Greetings and welcome to a presentation on building a sustainable program of evidence-based practice, a practical guide for the respiratory care professional. I'm Bob Brown, the developer and content manager of the Pulmonary Diagnostic Laboratory Resource Center that's located at www.pftlabresources.com. The purpose of this presentation is to provide the rationale, importance, and some potential options behind why and how to develop a program of evidence-based respiratory care information into your practice by using quality-focused principles. Just a quick note that while this presentation has a respiratory care focus, most of the information is applicable to all areas of healthcare delivery. So why am I interested in this topic? My professional careers have provided me with opportunities to be immersed in the healthcare quality world through actions, teachings, and publications. For the last 4+ years, while employed in Merck Medical Services Division of Vaccinology, Immunology, and Infectious Diseases, I had the opportunity to daily teach key opinion leaders on implementation science concepts and the importance of incorporating these principles when developing, monitoring, and implementing sustainable immunization programs within their organization. Additionally, prior to implementation science becoming a recognized field, I taught and published on methods to improve upon the quality of pulmonary diagnostic laboratory delivered services. So this presentation is around 60 minutes in length. The slides are numbered on the bottom right, so if you need to stop, simply note where you left off and pick it back up from there. If you have specific questions not answered in this presentation, please visit the Pulmonary Diagnostic Laboratory Resource Center at www.pftlabresources.com and send them to me along with your comments. My email is located in the contact page, and I'll make all attempts to get back to you in a timely manner. So with that as background, grab a beverage, a snack, get comfy, and let's get on with the program. I have no conflicts to report. Recently, numerous professional healthcare providers and organizations have advocated and adopted evidence-based practice into healthcare delivery. Many of these organizations support the concept that activities supported by evidence-based clinical practice guidelines should be prioritized to optimize healthcare delivery. Clinical practice guidelines are developed from evidence-based information and may also rely upon clinical expertise to support the guideline message. Clinical practice guidelines therefore provide the basis from which evidence-based practice can be incorporated into healthcare delivery. There is, however, not a direct pathway between clinical practice guideline information and how to successfully implement that information in actual clinical practice. This presentation will hopefully offer up new information on potential constructs to employ when developing an evidence-based program. My intent is not to tell you that this is the only way to do that, as you know your business and I don't. My intent is to overview some quality-focused concepts to consider when developing, monitoring, amending, and validating an evidence-based program. Hopefully, this specific activity would use the American Association for Respiratory Care Clinical Practice Guidelines, or for the pulmonary diagnostician, the ATS recommendations or standards, as the source of procedure-specific information. I'll overview some select process improvement models which may be incorporated into a quality-focused respiratory care service delivery plan or for other areas that have been identified for improvement. So ask yourself how you may apply quality improvement constructs into clinical practice, or at least within the context of departmental improvement initiatives. Granted, developing and implementing new programs is work. However, if the end results improve upon the delivery of care or improves a particular program, then it most certainly is worth the effort. Before we begin, I just want to frame up the focus of this presentation. First, some background and considerations addressing the impact of a changing healthcare environment, the importance of evidence-based practice, abbreviated as EBP, evidence-based practice, what's the payback for respiratory care? The next section will overview some select implementation science constructs, the plan, do, study, act cycle, the plan, implement, evaluate cycle, and the getting to outcomes 10 steps, Lewin's 3-step model, Lean Six Sigma, define, measure, analyze, improve, and control cycle, and finally the dynamic sustainability framework. Next, I'll overview some potential methods to apply these implementation science constructs to the evidence-based practice platform process. And then I'll wrap it up by looking at how to apply the implementation science constructs in the healthcare arena with a focus on respiratory care services. For background, the United States healthcare industry is slowly, and I do mean slowly, transitioning from quantity to quality. The healthcare environment has been in a state of transformation for numerous years. The delivery of U.S. healthcare costs have dramatically increased without foreseeable substantial abatement. As can be seen by the graph below, in 1960, approximately 5% of the gross domestic product, the GDP, went to healthcare expenditures. For all of 2021, healthcare spending accounted for about 18.5% of the GDP, including federal expenditures. Also, the need for quality patient intervention, that's the transition from volume-based to value-based care, along with provider and customer satisfaction, are key drivers for change. The next slide, we're going to address the value-based care concept, the quadruple aim. The triple aim was developed by the Institute for Healthcare Improvement, the IHI, in October of 2007. Building upon this, the University of Arkansas for Medical Science has adopted the quadruple aim. Currently, the quadruple aim has been an impetus to assist providers in appreciating what internal and external factors may be influencing the changing healthcare setting and/or system. The quadruple aim framework areas are considered to be drivers of today's changing healthcare system. The four cyclical components of the quadruple aim are essential and are dependent upon each other to maximize the patient and provider healthcare encounter. They are: improve the patient experience of care, including quality and satisfaction; improve the health of populations; reduce the per capita cost of healthcare. This is the transition from volume to value concepts; improve provider satisfaction, which includes professional wellness. Many of these factors are key contributors to consider when detailing the importance of evidence-based practice protocols to institutional decision makers. This concept will be discussed later on in the presentation. Continuing with the background information on transitioning from quantity to quality, understanding what some of the components of healthcare change might require does not necessarily translate into effectively developing and employing processes which could maximize improving the delivery of care. Therefore, the development of clinical practice guidelines, also known as CPGs, by professional organizations has been viewed as instrumental to adopt expert opinion and evidence-based information into clinical practice in order to improve the delivery of quality care. Translating clinical practice guidelines into actual clinical practice may be complex and therefore inconsistently implemented. CPGs provide the information on what the right intervention might be, however, they do not provide the how to do it. Sharing common goals between different disciplines, as well as having a multidisciplinary approach to patient care, would theoretically reduce redundancy and costs. They could also potentially improve upon the quality of care as well as the patient experience, going back to the quadruple aim. However, these types of activities may not be effectively developed, executed, and/or sustained due to a lack of understanding of the individual and related components, which are integral to assure program success. Transitioning to the next section, Evidence-Based Practice, Why Now? The American Association for Respiratory Care, the AARC, has begun in earnest readdressing the potential impact of evidence-based practice and what it may have on the delivery of respiratory care services. The next few slides will overview some important aspects of a changing healthcare environment and the potential impact on the sustainment of the respiratory care profession. As background, the first American Association for Respiratory Care clinical practice guidelines were published in Respiratory Care in December of 1991. Since that time, the AARC clinical practice guidelines have evolved and have been categorized as evidence-based clinical practice guidelines, of which there are 11, expert panel reference-based guidelines, of which there are 23, and AARC retired guidelines, of which there are 26. Continuing with evidence-based practice, why now? The Best Practices in Productivity and Staffing Value Efficiency was published as an AARC position statement effective November 2020. This paper illustrates the importance of high-quality delivery of respiratory care services due to increasing demands of payers, administrators, consultants, and patients. The next series of slides will hopefully provide a better understanding of how the American Association for Respiratory Care is taking action to address the changing healthcare landscape by encouraging respiratory care practitioners to better understand and enact the concept of value efficiency within their practice. Don't worry, I'm not going to review this article. However, I am going to cherry pick some key statements, which I've italicized or bolded, along with providing some recent AARC educational topics which will support the importance of evidence-based practice and ultimately respiratory therapist or technologist-driven protocols. The respiratory care value efficiency concept has been a work in progress and was first introduced at the AARC Congress in 2017. This article provides a philosophical rationale behind the importance of respiratory care practitioners to adopt and engage the concept of value efficiency. It's about raising the awareness of a changing healthcare environment and the potential survival of the respiratory care profession. There needs to be a focus on the quality of patient care among those who order treatments, those who provide those treatments, and ultimately those who pay for the treatments. Purchasers will continue to express a desire for more value for their dollar. The performance of any intervention and the individual providing the intervention must demonstrate both value and efficiency. According to Kaufman, while we all need to be efficient in our operations and services, what is most important is that we are delivering a positive outcome for our services. To best serve our patients, families, communities, and our organizations, we need to pivot from busyness to effectiveness. In the accompanying editorial of the article Determining the Value Efficiency of Respiratory Care, I think the key takeaways are understanding the importance of evidence-based practice and how to apply this principle in the delivery of respiratory care, especially as it applies to the development and implementation of clinical practice guidelines into clinical practice. Based upon where healthcare arena is moving, respiratory care practitioners need to be the evidence-based practices leader within their own and extended teams. This shouldn't just fall on managers to carry this out. To practice near the top of their skill level is not a new concept, nor is stopping the repetition of menial, low-level tasks poorly supported by evidence. With detailed published resources available, such as the AARC Clinical Practice Guidelines, we should have a high degree of confidence that evidence-based practice may be employed for many of the commonly performed respiratory care procedures. However, as with many things in an evolving healthcare environment, this topic should be closely monitored to have a good understanding if and or when changes need to occur. This webinar provided the metrics and applications behind the article Determining the Value Efficiency of Respiratory Care. The article and editorial by Hess are must-reads. This webinar is a must-see. The respiratory care community needs to be well-versed on this topic so that we too can survive the changing healthcare environment. We need to rethink how we do business in an environment of perpetual rising costs and declining number of potentially qualified credentialed individuals. When there's an opening in your department and you're having difficulty filling the position, can you look outside the respiratory care pool? For example, as a credentialed professional, what procedures can be farmed out to, say, less credentialed or on-the-job trained personnel? Also, what highly repetitive procedures do you offer that can have their frequency be modified, hopefully by being identified through a respiratory therapist-driven protocol? Such suggestions and concepts may make you feel uncomfortable, but think about the long-term implications and prospects if you don't potentially modify how you work. Remember, it's all about quality and not quantity. The next few slides will briefly illustrate how the American Association for Respiratory Care has recently placed added focus on evidence-based practice through live educational topics. The first day of the AARC 2022 Summer Forum kicked off with a plenary session focusing on using systematic reviews and clinical practice guidelines to create evidence-based practice. The importance of patient-focused respiratory care protocols, which is a term that may seem more neutral in tone than respiratory therapist-driven protocols, is evident by the emphasis the AARC placed on instituting them as best practices through educational venues. Continuing with the concepts of rising healthcare costs and the necessity to improve the efficiency of delivered services, implementation of validated protocols may be one solution to meet these needs. The American Association for Respiratory Care and the American Thoracic Society have already provided the essential information foundation when designing an evidence-based practice program in the form of either respiratory therapist-driven protocols or technologist-driven protocols. Protocols that are well designed and validated, that's the key word, validated, add value to your facility and to the organization by reducing procedure variability, improve the efficiency, consistency, and the quality of delivered services. Proven quality-focused constructs are critical for successful implementation and program sustainability. Well, that's it for background, and I realize that I front-loaded a ton of background information for this topic, and I thank you for your patience. I simply wanted to highlight some key external and internal factors that are influencing how healthcare is evolving. Some of these factors may not be all that favorable to the respiratory care profession. However, other factors may provide opportunities for the respiratory care profession to improve upon the delivery of care. Having a good understanding how implementation science constructs combined with evidence-based practice can influence care delivery will hopefully accomplish this in a positive manner. Let's review how select implementation science constructs could be utilized when developing a sustainable, quality-focused respiratory care initiative. As I review this material, keep in the back of your mind how this information might be applied when developing a respiratory therapist-driven protocol. So, what are implementation research and implementation science? A recently developed area of research, implementation research, and its interconnected discipline, implementation science, have been embraced and endorsed by some health-focused educators, professional societies, and organizations. By definition, implementation research is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence, to improve the quality and effectiveness of health services. According to the definition proposed by the National Implementation Research Network, implementation science is the study of factors that influence the full and effective use of innovations in practice. The goal is not to answer factual questions about what is, but rather to determine what is required. Also, the National Institute of Health defines implementation science as the study of methods to promote integration of research findings and evidence into healthcare policy and practice. Therefore, for this purpose, implementation science may be considered to be the structured link between translational research and evidence-based medicine, clinical practice, interventions, and outcomes. A major implementation science stipulation is an intervention will not succeed if it is not implemented properly, even if it has been shown to be effective in research. For that reason, with the goal of improving the quality of health care, implementation science complements and enhances the transition from focus primarily on quality improvement initiatives. Additionally, numerous healthcare professional organizations such as nursing, neurology, psychiatry are encouraging their members to be more proficient in understanding implementation science principles and applying them in practice. The primary intent is to improve the quality of delivered patient care. For example, the American Thoracic Society has recently published a position paper on implementation science. As I go through this presentation, keep the message from this slide in the back of your mind. Proven implementation science constructs, for example, the Plan, Do, Study, Act cycle, plus evidence-based practice results in high-quality healthcare service delivery. With the goal of improving the quality of healthcare and healthcare delivery, implementation science incorporates aspects of continuous quality improvement, but builds upon and may also focus on many of its aspects. When looking at the stages of implementation, exploration, installation, initial implementation, and full implementation are components commonly incorporated for any aspect of a healthcare system into the implementation science process. This table outlines key implementation science process components. Okay, let's move on to the next section on pre-implementation. The pre-implementation section listed here are the areas that will be overviewed regarding the importance of focusing on processes when developing, evaluating, modifying, and implementing a quality-focused initiative. First thing we'll look at is what is readiness. Next, we'll move on to defining a model for improvement along with examples of select implementation strategies listed here. First up is readiness. Organizational readiness is the extent to which an organization is willing and able to implement a particular innovation. Using R equals MC squared may help identify the specific level of organizational readiness and determine the areas in need of improvement and areas of relative strength that can be used to improve organizational readiness. Prior to developing a construct for a new innovation, the organization must ask itself if the proposal is appropriate and if the organization is ready to make the change. Scasey et al. Proposed a basic concept to assess organizational readiness, R equals MC squared, whereby readiness equals motivation times general capacity times innovation-specific capacity. This group proposed that organizational readiness incorporates three distinct components which could be assessed independently. Number one, the motivation to implement an innovation. Number two, the general capacities of an organization. And number three, the innovation-specific capacities needed for a particular innovation. In general, as described by the authors, motivation is defined as perceived incentives and disincentives that contribute to the desirability to use an innovation, which includes beliefs about A, and an innovation, and B, support for the innovation that contribute to the innovation use. General capacities comprise attributes of a functioning organization, for example, sufficient staffing, effective organizational leadership, and connections with other organizations and the community. Innovation-specific capacities are the human, technical, and physical conditions that are important for successfully implementing a particular innovation with quality. Based on initial levels of each readiness, specific strategies can be identified, delivered, and finally evaluated for effectiveness. Using the organizational readiness for implementing change principle 10 steps to determine organizational readiness should hopefully improve the feasibility of implementing a new or modifying an existing program. Prior to developing concrete strategies and organizing teams, assessing organizational readiness for change is an essential first step. Think how receptive your institution would have been if you wanted to immensely change the way you did business during the height of the SARS-CoV-2 pandemic. What are models for improvement? A model for improvement can be defined as an integrated approach to process improvement that helps deliver quick and substantial results in quality and productivity. While a number of healthcare improvement models have been described in the literature, the following are some examples which may be suitable for assimilation into respiratory care practice. I'll start with the most common pre-implementation strategy examples used: the Plan, Do, Study, Act cycle, the Getting to Outcomes 10 steps, and the Plan, Implement, Evaluate cycle. I've previously extensively reviewed the potential application of the Plan, Do, Study, Act cycle and the Getting to Outcomes 10 steps and Plan, Implement, Evaluate cycle in the posted video presentations. They may be found on the links listed here or by simply going to the Pulmonary Diagnostic Laboratory Resource Center at www.pftlabresources.com and opening up the resources page. However, because of their importance when considering how to develop, monitor, amend, and implement an evidence-based practice program, the next few slides will highlight some key aspects of each implementation construct. The Plan, Do, Study, Act cycle is a process planning progression that, because of its design, continuously involves the user to document, collect, and evaluate data against the original proposal, the plan. Unlike the top-down Plan, Do, Check Act cycle, the Plan, Do, Study, Act cycle methodology additionally allows for the option of abandoning the proposed plan if the collected data does not support the original prediction, the plan. As one of the most important aspects of the Plan, Do, Study, Act cycle involves all staff in assessing problems and suggesting and testing potential solutions. This bottom-up approach increases the likelihood that staff will embrace the change or changes, which is a key requirement for successful quality improvement. Let's focus on the key takeaways from the Plan, Do, Study, Act cycle. Plan, P. Plan the test, including a plan for collecting data. Do, D. Run the test on a small scale. Study, S. Analyze the results and compare them to your predictions. Act, A. Based upon what you learned from the test, make a plan for your next step. Adapt, make modifications and run another test. Adopt, test the change on a larger scale. Or abandon, don't do another test on this change idea. Keeping the PI cycle framework in mind, respiratory care practitioners could effectively incorporate the GTO's 10 steps into a quality-focused implementation plan strategy. A 2007 jointly supported technical report from the Centers for Disease Control and Prevention and RAND Health entitled Getting to Outcomes 10 Steps for Achieving Results-Based Accountability provides a concise overview and potential applications of the 2004 RAND Corporation publication. This succinct document could serve as a roadmap for developing, implementing, monitoring, and evaluating a quality-based improvement program. The plan, implement, evaluate cycle elements are straightforward in their approach to achieving positive outcomes. Plan, P. Plan effective programs that are accountable to stakeholders and help achieve intended outcomes. Implement, I. Implement the programs. Evaluate, E. Evaluate the programs to see how well they worked and continuously improve them, providing outcomes data to key stakeholders. Having a good understanding on how the Getting to Outcomes construct can be applied to the development of new or modifications to existing healthcare initiatives should assist the respiratory care practitioner to embrace and easily integrate the 10 steps into practice. The Getting to Outcomes 10 steps are broken down into two sections. Steps 1 through 6 are planning. Step 1, conduct a needs assessment. Choose which problem to focus on. Step 2, identify goals for the program, the people you want to target with the intervention, and desired outcomes or objectives. Step 3, look for existing programs and best practices worth adopting. Step 4, examine the program you choose and see how well it fits the needs of your target population and community. Step 5, assess whether your organization has the capacity to implement the program. And Step 6, make a plan for implementing the program. Steps 7 through 10 are evaluating and improving. Step 7, think ahead about how you will know whether the program has been implemented successfully. Step 8, think ahead about how you will measure whether the program meets its goals, reaches its target audience, and achieves its desired outcomes. Step 9, make a plan for continuous quality improvement of the program. And Step 10, consider what will be needed to keep the program going if it's successful. Moving on, let's take a look at Lewin's three-step model, which is employed to increase organizational readiness. Lewin's change management model, understanding the three stages of change, was first introduced in the 1940s. Since then, process improvement innovators have embraced his findings to better understand organizational change and incorporate them into process and change models. Lewin's model suggests that change can be ascribed as a three-step process of unfreeze, change, refreeze, which is summarized below. Stage 1. Unfreeze the status quo. Change can be difficult for many. Some individuals may resist change as they may actually benefit from the status quo. Therefore, a persuasive message must be developed and delivered so that there is a clear understanding of why change must be adopted. To ensure organizational buy-in, it's imperative to communicate the rationale for change. When developing the communication, ensure that the message clearly and succinctly addresses the reasons, urgency, as well as how staff may be affected by the change. Invite participation by select individuals who are being affected by the change. This active engagement may be motivational for many, as there is a tendency for people to support initiatives that they have been empowered to help create. If necessary, specific actions may be necessary to unfreeze attitudes to change within the organization. Stage 2. Change. During this stage, people begin to understand the importance of the change and to look for new approaches to doing things. Structured brainstorming may be an integral component of this phase. While not always understood by agents of change, extended time may be necessary for some to accept and embrace the new direction. This phase may require additional managerial hands-on to re-emphasize the intent and the importance for acceptance by those who are resistant to change. Stage 3. Refreeze. This stage is achieved after people have accepted and incorporated the new change. This acceptance is measurable simply by assessing the frequency that is employed in everyday business. When the changes are taking shape and people have embraced the new ways of working, the organization is ready to refreeze. The outward signs of the refreeze are a stable organization chart, consistent job descriptions, and so on. The refreeze stage also needs to help people and the organization to internalize or institutionalize the changes. This means making sure that the changes are used all the time, and that they are incorporated into everyday business. With a new sense of stability, employees feel confident and comfortable with the new ways of working. The rationale for creating a new sense of stability in our ever-changing world is often questioned. Even though change is a constant way in many organizations, this refreezing stage is still important. Without it, employees get caught up in a transition trap where they aren't sure how things should be done, so nothing ever gets done to full capacity. In the absence of a new frozen state, it's very difficult to tackle the new change initiative effectively. How do you go about convincing people that something needs changing if you haven't allowed the most recent changes to sink in? Change will be perceived as change for change's sake, and the motivation required to implement new changes simply won't be there. Additionally, sometimes specific actions may be necessary to unfreeze attitudes to change within your own organization. And finally, for this section, let's look at the Lean Six Sigma define, measure, analyze, improve, and control cycle, abbreviated as the DMAIC cycle. While definitions may vary, Lean Six Sigma is commonly described as a fact-based, data-driven philosophy that provides organizations tools to improve the capability of their business processes. Improving performance and decreasing process variation may help lead to deficiency reduction and improvement in output, employee morale, and the quality of products or services. The DMAIC cycle consists of 5 phases: define, D, measure, M, analyze, A, improve, I, and control, C. This is the problem-solving methodology behind Lean Six Sigma. The DMAIC cycle components are broken down as follows. D, define. Define the problem. Confirm with data that there's an ongoing problem and the negative impact that this problem is having on the business environment. Are there existing resources that can assist with resolving of the problem? Development of a goal statement is recommended in this phase, which also includes mapping out processes and defining internal and external customers and their stated proposed requirements to solve the problem. M. Measure. Map out the current process. Establish a performance baseline before instituting change to serve as the standard against which any change can be measured. Consider the root cause or causes of current performance levels and develop a plan to collect and analyze reliable data to ultimately ensure that decisions are based upon comprehensive information. Measures inform whether the changes that are being made actually lead to improvement. A. Analyze. Identify the cause of the problem. Structured brainstorming sessions may be a method to develop theories about potential causes of the problem. The team reviewing the initial collected data that may also decide that additional information may be useful in the analytical phase. Oftentimes, displaying the data as a chart and/or graph may enable team members to have a better understanding of the information and allow them to more readily verbalize findings to leadership or other interested parties. I. Improve. Implement and verify the solution. Once the team is satisfied that accurate and reliable data has been obtained to ensure informed decisions, an improvement solution can be developed, communicated, implemented, and monitored and measured. At this point, the team can incorporate the Plan, Do, Study, Act cycle to achieve this phase. And finally, C. Control. Maintain the solution. Once a plan has demonstrated success, the team needs to develop a structured strategy on how to pass it along to other employees and ensure successful implementation, monitoring, documentation, and fidelity. Sharing project data and findings with internal customers and external teams, including multidisciplinary teams, may be helpful in maintaining the solution, while also enabling others to recognize areas for improvement and develop similar solution-based strategies within their work environment. To re-emphasize, make certain to consider the overall root cause or causes of current performance and identify specific actions for achieving the best results. The summary for pre-implementation is as follows. Readiness is a necessary precursor to successful organizational change. The model for improvement is an integrated approach to process improvement. Some examples of implementation science strategies have been provided, and it's important to understand and select the improvement model that works best for both your organization and your initiative. Let's move on to the next section, implementation. Recent research suggests that utilizing the principles of design thinking may be helpful when creating and implementing a meaningful organization change. By definition, design thinking is a design methodology that provides a solution-based approach to solving problems. Some researchers suggest that solving ill-defined or unknown complex problems might best occur with a better understanding of the human needs involved in a change, reframing the problem in human-centric terms, as well as incorporating structured brainstorming sessions and adopting a hands-on approach in prototyping and testing of the proposed solution. When designing a meaningful intervention, there are 5 areas to consider. First, empathize. Research the user's needs. Since the agent of change may not be directly involved in a specific area, observing what people do and how they interact with each other and their environment may provide clues about what they think and feel. These insights could allow for more meaningful direction to create innovative solutions. Second, define. State the user's needs and problems. Take the information obtained in the empathize section and analyze it to determine the core problem or problems that the change agent and team have identified. Develop a problem statement in a human-centered manner to personalize and enhance ownership what needs to be addressed. Third, ideate. Challenge assumptions and create ideas. Look for alternative ways, for example, structured brainstorming, best practices, benchmarking, etc., to view the problem and identify innovative solutions to the problem statement that was created in the define section. Stages 4 and 5 go together. Stage 4, prototype. Start to create solutions. The emphasis is to identify the best possible solution for each of the problems identified during the first 3 stages. Stage 5, test. Try solutions out. Implement and evaluate and measure the prototype solution. The test stage allows the users to revisit the previous stages in the process to make further iterations, alterations, and refinements to rule out alternative solutions. And finally, to re-emphasize, consider what might also be needed to be incorporated into the design and planning process once full implementation is rolled out across the organization. Implementation drivers are critical to effecting change where they are designated as the engine of change. The National Implementation Research Network, the NIRN, undertook a systematic review of qualitative literature and best practices of successfully implemented practices and programs and assembled lists of the barriers and facilitators that were identified from each of the searches. Active implementation drivers arose from these lists, whose roles are considered dynamic and interactive for the purposes of driving change in consistent and innovative ways. These interactive processes are integrated to maximize their influences on staff and the organizational culture. Additionally, the implementation drivers augment each other by compensating for the inherent weakness of each component. The next few slides will list the organizational implementation drivers and their prospective offerings as identified by the NIRN study. First up is organization. Next is leadership. And finally, competency. Implementation teams play an active role by providing an internal support structure to help move innovations through the stages of implementation. These teams ensure that the implementation infrastructure is effectively assimilated to support the proposed practice or program. Implementation teams commonly focus on increasing buy-in and readiness, installing and sustaining the implementation infrastructure, assessing and reporting on fidelity and outcomes, building linkages with external systems, problem solving and promoting sustainability. Oftentimes, due to resource limitation, a single champion is designated to assuring proper implementation of a new program. In this case, the long-term success of the program may be limited if the champion can no longer fulfill his or her responsibilities. Therefore, the team approach may be more beneficial to ensure sustained success of the new and existing programs. Additionally, when multiple teams are engaged in a larger scale change effort, they need to be firmly connected to ensure proactive communication and engage in problem-solving activities. The purpose and functions of each team needs to be clearly defined and known to all other teams. In summary then for implementation, use principles of design thinking to help create a meaningful change that's right for your organization. Some key principles of design thinking include empathize, define, ideate, prototype, and test. Implementation drivers are critical to implementing change. Implementation teams provide an internal support structure to help move innovations through stages of implementation. Okay, let's move on to the topic of sustainability. Despite the annual investment of tens of billions of U.S. tax dollars on health research and progress in developing, testing, and implementing evidence-based healthcare practices, we have limited understanding of how to sustain quality healthcare and routine services. The intent of this section is to overview some common models which support and enhance program sustainability. From an implementation point of view, any innovation, evidence-based or otherwise, is incomplete without a good measure of fidelity to detect the presence and strength of the innovation in practice. Fidelity assessment measures the strength of the innovation and enables improvement in the implementation plan and process with the goal of program sustainability. Fidelity assessment should be frequent, relevant, and actionable. Fidelity is directly linked to program outcomes. If findings do not suggest good outcomes, then the plan may need to be modified or completely redesigned and started over. It's perfectly fine to recognize that the first iteration of the plan wasn't perfect. That's why you measure and make adaptations. Let's look at sustaining change with the use of the Dynamic Sustainability Framework, the DSF. In real-world settings, change occurs over time. Because of this phenomenon, ongoing optimization of fit through adaptive continuous quality improvement is required to ensure intervention sustainability. Traditionally, implementation project sustainability was assessed with a variety of methods, for example, needs assessments, long-term action plans, tracking of program adaptation, financial planning, etc. However, these methods may only be applicable in a static delivery system, requiring periodic assessment and not in an ongoing manner. As previously stated, all aspects of healthcare are undergoing tremendous rapid transformations. In many cases, departments are cross-fertilizing procedures, personnel, and other resources. According to Chambers, the DSF emphasizes that change exists in the use of interventions over time, the characteristics of practice settings, and the broader system that establishes the context for how care is delivered. This model emphasizes three focus areas: importance of context, the need for ongoing evaluation and decision-making, and the goal of continuous improvement. This chart provides a quick summary when contrasting the static views of sustainability with the Dynamic Sustainability Framework. Unless you plan to return this slide, I suggest taking a screenshot or reviewing the Chambers reference listed at the end of this presentation. The DSF assesses the fit between overlapping areas which are encountered in the healthcare arena. These overlapping areas contain and are characterized as intervention, including components, practitioners, outcomes, and the delivery platform; the practice setting, including staffing, information systems, origination, culture, climate structure, business model, training, and supervision; and the ecological system, other practice settings, including policy, regulations, and market forces. In summary, in the real world, change occurs over time. Therefore, ongoing optimization of fit through adaptive, continuous quality improvement is an important aspect of sustaining change. Sustainability can be viewed as a dynamic process and as such can remain viable if the change agent keeps the 7 DSF tenets in mind when developing implementation strategies, for example, using the Plan, Do, Study, Act cycle for a new program, as well as modifications to existing programs. The 5 key components of the sustainability research landscape are: number 1, context and factors. For example, what are organizational issues and factors affecting sustainability? Number 2, measure and analyze, that is, design a framework and measure progress. Number 3, define and conceptualize, that is, evaluate the framework and define success. Number 4, program funding and practice training. And number 5, return on investment and adaptation. In summary then, for sustainability, fidelity assessments are important to measure the success of your implementation. Assessments should be frequent, relevant, and actionable. In the real world, change occurs over time. Therefore, ongoing optimization of fit through adaptive, continuous quality improvement is an important aspect of sustaining change. Consider using the Plan, Do, Study, Act cycles to continuously improve performance and optimize fit. And sustainability can be broken down into 5 key components: context and factors, measure and analyze data, define and conceptualize, training and funding, and return on investment and adaptation. The next step when developing an evidence-based practice program, we're going to focus on implementation process teams. Be patient with the process, as decision makers and team members may have competing priorities. Developing a detailed overview of your plan may make it easier for extended teams to have a better understanding and appreciation of the importance of your plan for change. Also, if your organization has the capacity, it may be beneficial to include statements around how, since the protocol will focus on providing the right intervention on the right patient at the right time. We will be monitoring the pilot program as well as the long-term program for effectiveness in reducing costs. Cost reduction might occur with earlier hospital discharge, reduced return and ED visits, or hospital readmission, etc. While not comprehensive, the following is a potential listing and role of multidisciplinary team members. Ideally, you would have administration and the medical director in the room when you're detailing the importance of this project. That way, first pass questions can be heard and answered during one sitting versus numerous back and forth discussions. This saves time and frustration. Having representation from the Department of Quality is essential, as they have a good understanding of process development, implementation strategies, and they would be an excellent resource. Representation with nursing is an essential component of your development process team, as they may need to interface with internal and/or external clients and provide a brief description of the project intention. Not all respiratory care practitioners need to be involved in all aspects of the process. Select respiratory care practitioners could assume leadership capacities with this project and solicit, collate, and report feedback from respiratory therapy overlays on their thoughts, constructive feedback, application, etc. on the project. These lead respiratory therapists could also apprise their colleagues of project progression, thereby keeping the entire respiratory care team updated in a timely manner and making them part of the process. This next section will review some potential applications of implementation science constructs and how they may be integrated when designing, evaluating, implementing, and modifying a sustainable healthcare initiative. This slide will look at the potential application of the Plan, Do, Study, Act cycle on pH blood gas analyzer operability, looking at calibration, calibration verification, and quality control, QC. Keeping the following concepts in mind, the PDSA cycle can be implemented for a number of areas in respiratory care. What are we trying to accomplish? The aim is to determine which specific outcomes you're trying to change. How will we know that a change is an improvement? By identification of the appropriate measures to track your success. What change can we make that will result in an improvement? Identify the key changes that you will actually test. This example suggests how the Plan, Do, Study, Act cycle can be employed when assessing functionality of a pH blood gas analyzer. P. Plan. Assess pH blood gas analyzer operability. Do. D. Introduction of calibration agents. Maintain a record of date and time of calibration. Troubleshoot if the quality control results are unacceptable. Rectify the malfunction and recalibrate. Record the intervention. Maintain a record of the date and time of recalibration. S. Study. Calibration verification. Quality control product or products analysis. Do derived results fall within predetermined, expected, or acceptable ranges? Act. A. Use the instrument if the quality control product run or runs are acceptable. Maintain a record of the date, time, quality control material lot numbers, and derived data. Do not use the instrument if quality control results are unacceptable. Troubleshoot the source of error and repeat the Plan, Do, Study, Act cycle until problems are rectified. And as an added benefit, do proficiency testing as directed. Now, let's examine the potential application of the Getting to Outcomes GTO 10 steps and the Plan, Implement, Evaluate, the PI cycle, and how they may be applied to a patient-focused respiratory care protocol developed from the American Association for Respiratory Care Clinical Practice Guideline. This Clinical Practice Guideline, CPG for short, is one of many expert panel reference-based guidelines developed and endorsed by the American Association for Respiratory Care. I chose this particular CPG since it may be a common procedure across the United States. It's used here to illustrate how the Getting to Outcomes 10 Steps process may be utilized to break down key elements of this CPG, which is 14 pages in length, into a format that may make it easier to apply that information for the respiratory care practitioner to use it in the delivery of high-quality patient care, possibly via a respiratory therapist-driven protocol. This is my interpretation on how this GTO 10 steps construct may be applied to a specific American Association for Respiratory Care clinical practice guideline. Your interpretation may be different, and that is absolutely encouraged. Remember, clinical practice guidelines provide the what the right intervention might be. However, they do not provide the how to implement the information into care. Unless you plan on returning to this presentation, I suggest that you take a print screen of the next 2 slides for reference. Of course, these 10 steps would only be used as a secondary reference, a quick visual aid as it were, as the actual clinical practice guideline would be readily available to serve as a primary reference. The first 6 steps are for planning. And then steps 7 through 10 focus on evaluating and improving. While this example reads like a policy and procedure, the format is designed using the Getting to Outcomes 10 Steps framework and key components of the 2012 AARC Clinical Practice Guideline. The beauty of the GTO 10 Steps format is that it's flexible to make amendments when new scientific information is available, as well as adaptable to a changing patient condition, while utilizing the team approach to decision making. The Plan, Implement, Evaluate cycle and/or the Plan, Do, Study, Act cycle implementation science constructs can also be incorporated into this plan to continuously assess the effectiveness of the therapeutic intervention, as well as modify therapy as the patient condition changes. For this next example, we'll be looking at the evaluation of an existing pulmonary rehab program to reduce readmission and emergency department visits using the dynamic sustainability framework concept. This example incorporates concepts from the DSF to evaluate the feasibility of developing, implementing, and documenting a treatment modification strategy to an existing pulmonary rehab program. Employing a multidisciplinary strategy, qualified pulmonary rehabilitation respiratory care practitioners would provide home visits to recently discharged COPD patients with the goal of reducing hospital readmissions and emergency department visits. This real-world pilot model illustrates how DSF concepts may be applied to the modification of an existing pulmonary rehab program by utilizing, in this instance, the respiratory care practitioner as a key multidisciplinary driver with the intent of reducing ED and hospital readmissions. Additionally, the Plan, Do, Study, Act cycle is reinforced within the cycle to ensure that continuous quality improvement is included and sustained within this process. In this instance, the DSF model format allows flexibility in who should be the change driver, along with identifying and including additional key individuals necessary to plan and optimize care post-discharge. As always, in a multi-care patient approach, communication about the various care planning objectives, implementation steps, process monitoring, and outcomes reporting is vital to ensure program and patient successes. In the United States, enormous sums of resources are expended each year in healthcare with, oftentimes, less than optimal return on investment. In an effort to improve upon the delivery of care, since the late 20th century, focus was placed on healthcare quality improvement, which has been met with mixed success. Applying process concepts that were designed for industry has been less than optimal in a fluid, dynamic environment such as healthcare. Undertaking change can oftentimes be perceived as a daunting challenge, even if evidence suggests that the change is necessary. Having a clear understanding of potential quality improvement processes can assist the change agent in successfully designing, implementing, measuring, and instituting new or modifications to existing programs. Implementation science principles and how they are intimately linked with healthcare quality programs should enable the respiratory care change agent with developing processes that improve sustained delivery of quality care. Understanding organizational readiness for change is paramount prior to even considering designing an improvement project and/or instituting a new program. Such an understanding reduces program development time wasted and overall frustration in trying to implement a program that may not be perceived as valuable. Some healthcare organizations have advocated for their members to embrace and enact implementation science principles within their scope of practice. Now is the time for respiratory care providers to follow their colleagues' examples to improve quality within their respective areas by adopting a focus on evidence-based practice and partnering with the field of implementation science. And finally, with all the information just reviewed, think about this scenario and ask yourself what you would do to assure program sustainability and assure that all employees are understanding and adhering to the evidence-based practice plan. How will you incorporate the information into a format, a construct, that includes assessment of the original proposal regarding dissemination of project proposal information to pertinent organization members, and what resources are necessary for the project? And how will you go about assessing the understanding of the project through communication to team and extended team members, through documentation and demonstration of initial understanding and competence assessment, as well as documentation and demonstration of continued understanding and competence assessment? What will be some suggestions for the frequency of monitoring the project effectiveness? How will you assess if the goals are being attained and maintained? If not, does the proposal need to be adapted? And finally, will the project need to continue, be amended, or simply need to end? Remember, this is a process and not a race. It's also work, but it sure is satisfying to be impactful and improve the delivery of care. The next few slides list most of the references that I used for the development of this presentation. And I suggest that unless you plan on viewing these slides again, that you take a screenshot of this information. For those of you who are interested in this topic, I highly suggest visiting the Institute for Healthcare Improvement, the IHI website, as it contains numerous resources and many of them are free. And guess what? Here are some more suggested readings. And here's the final suggested reading slide. These are some of the related resources that can be found on the Pulmonary Diagnostic Laboratory Resource Center website at www.pftlabresources.com. Some of the concepts presented while Pulmonary Diagnostic Services focused have applicable information to all areas of respiratory care. For those who may not be familiar with implementation science concepts and how they are intimately linked to the high-level healthcare delivery, the primer of key concepts located with the implementation science focus area may provide a good introduction to the topic. There are also video presentations and links on the Plan, Do, Study, Act cycle and the Getting to Outcomes 10 Steps and Plan, Implement, Evaluate cycle. This particular video and link will also be added to the implementation science focus area, as well as being listed in the respiratory care, the RC Quality Corner. Okay, that's it. Thanks so much for taking time out of your busy schedule today. Hopefully there were some new insights or some information that supported what you already knew. Either way, please share your thoughts. My contact information can be found on the Pulmonary Diagnostic Laboratory Resource Center located at www.pftlabresources.com. Also, while on my website, check out the other focus areas by double-clicking on the Resources tab. Thanks so much. Take care.